Welcome to this Pearl of Laboratory Medicine, brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls, as well as other free educational material at traineecouncil.org.
Hello, my name is Qing Meng. I'm the Section Chief of Clinical Chemistry and a professor in the Department of Laboratory Medicine at the University of Texas MD Anderson Cancer Center. Welcome to this Pearl of Laboratory Medicine on hypercortisolism. Here are the objectives. After participating in this presentation, you will be able to understand the different etiology and pathophysiologies of hypercortisolism, to discuss the screening tests for Cushing syndrome, and hopefully to establish diagnostic approach and differential diagnosis of Cushing syndrome. Cortisol is regulated through a hypothalamic pituitary adrenal axis. Corticotropin-releasing hormone, or CRH, is released by hypothalamus under stress, exercise, and hypoglycemia. This elicits episodic and scaling secretion of adrenal corticotropin hormone, or ACTH, by pituitary gland. Secreted ACTH then stimulates the adrenal glands to produce cortisol, which provides negative feedback inhibition to the CRH and ACTH axis. The secretion of cortisol is featured by pulsatile secretion and scaling rhythm. The disorder of adrenal cortex can be divided into adrenal cortical hyperfunction and adrenal cortical hypofunction. One of the adrenal cortical hyperfunction disorder is hypercortisolism, or Cushing syndrome. Now let's talk about hypercortisolism, or Cushing syndrome. Cushing syndrome is a group of clinical abnormalities, including symptoms, physical signs, metabolic, and biochemical changes due to chronic exposure to high levels of cortisol. The incidence of Cushing syndrome is 10 to 15 per million and mostly occur between the ages of 20 to 50 years. Cushing syndrome was first described by Harvey Cushing, an American neurosurgeon, in 1912. This is where the name came from. Based on the causes of cortisol hypersecretion, Cushing syndrome can be classified as ACTH-dependent or ACTH-independent. Hypersecretion of ACTH by pituitary microadenoma is the primary defect, leads to a bilateral adrenal hyperplasia, cortisol overproduction, and then the characteristic clinical picture. This is called Cushing disease. It accounts for 70% of the cases of Cushing syndrome. Some non-pituitary, non-endocrine tumors, such as lung, ovarian, and carcinoid tumors, can also secrete ACTH, resulting in adrenal hyperplasia and overproduction of cortisol. This is called ectopic or non-pituitary Cushing syndrome. Patients with primary adrenal disease, such as adrenal adenoma, adrenal carcinoma, or other type of tumors, can increase the secretion of cortisol with the phenotype and Cushing syndrome, but they are independent of ACTH stimulation. Long-term exogenous or iatrogenic administration of glucocorticoids can also cause ACTH-independent Cushing syndrome. A group of conditions such as alcoholism, depression, obesity, polycystic ovary syndrome, associated with the clinical and biochemical features of Cushing syndrome, is called pseudo-Cushing syndrome, but the hypercortisolemia is usually secondary to other factors. So, what's the difference between Cushing syndrome and Cushing disease? Actually, both Cushing syndrome and Cushing disease are caused by oversecretion of the adrenal cortisol. Cushing syndrome refers to the general state characterized by excessive production of cortisol and classic symptoms such as obesity, red face, moon face, buffalo hump, thin extremity, pink or purple stripe, and thin skin, etc., etc. Cushing disease is specifically meant for the pituitary-dependent form of Cushing syndrome caused by oversecretion of ACTH by pituitary tumors, primarily by microadenoma. What are the common causes of ectopic ACTH secretion? In such cases, which means ACTH is secreted by tumors outside of pituitary and adrenal glands. These include neuroendocrine tumors, including carcinoid tumors of the lung or bronchi, carcinoid tumors of pancreas, carcinoid tumors of thymus, and medullary thyroid carcinoma. There are also others, such as small cell carcinoma of the lung and pheochromocytoma. The diagnosis of hypercortisolism mainly relies on clinical manifestations and laboratory findings. For lab testing, serum cortisol and 24-hour urinary-free cortisol are used for primary screening tests. Suppression or stimulation tests are needed in order to make the diagnosis, while plasma ACTH is not the first-line test. Sometimes imaging study, such as CT and MRI, is used to localize the lesion. Here is the list of lab tests. Overall, in Cushing syndrome, you would expect to see high serum cortisol levels. Plasma ACTH levels may be elevated in ACTH-dependent Cushing syndrome, particularly in ectopic ACTH-secreting tumors, while in pituitary tumor, ACTH could be normal or only moderately elevated. 24-hour urine cortisol levels are elevated. There's a loss of diurnal variation in cortisol levels in Cushing syndrome. Dexamethasone suppression tests can be used for further investigation on confirmation and differentiation of ACTH-dependent or independent Cushing syndrome. Let's look at the screening tests for Cushing syndrome. There will undergo two steps of investigation for Cushing syndrome, the screening test and the diagnostic test. Two simple screening tests are usually conducted for detecting Cushing syndrome. One is the measurement of the 24-hour urine-free cortisol, and another reliable and convenient screening test is the overnight low-dose dexamethasone suppression test with the measurement of cortisol at 8 a.m. the next morning. A midnight cortisol measurement is the plasma salivary cortisol is also used to examine the morning to night difference of cortisol or to determine the circadian rhythm. Hypercortisolism is strongly suggested when any 2 out of 3 tests are abnormal. I'll explain a bit more in detail for each of the tests in the next few slides. A 24-hour urine cortisol can eliminate the circadian variation and give an overall estimate of blood cortisol levels. In some studies, the diagnostic sensitivity and specificity of urine-free cortisol are 100% and 98% respectively. Therefore, 24-hour urine-free cortisol measurement is considered to be the best screening test for hypercortisolism. A 24-hour urine-free cortisol concentration less than 50 micrograms per day would exclude the diagnosis of Cushing syndrome. On the other hand, a 24-hour urine-free cortisol concentration greater than 120 micrograms per day suggests the diagnosis of Cushing syndrome. Keeping in mind that urine cortisol measurements do not establish the diagnosis, and abnormal results need to be followed by further investigation. Let's talk about the dexamethasone suppression test. Dexamethasone is an exogenous steroid that provides negative feedback to the pituitary gland to suppress the secretion of ACTH. The dexamethasone suppression test is used to assess adrenal gland function by measuring how cortisol levels change in response to dexamethasone. For the overnight low-dose dexamethasone suppression test, 1 milligram dexamethasone is given orally at 11 p.m. Then serum cortisol is measured at 8 a.m. next day. If serum cortisol is suppressed to less than 2 micrograms per deciliter, it is considered normal. Serum cortisol greater than 2 micrograms per deciliter may be seen in cases of stress, obesity, infection, acute or chronic illness, alcohol abuse, severe depression, oral contraceptive use, pregnancy, estrogen therapy, etc. While in Cushing syndrome, serum cortisol is not suppressed, and the cortisol level greater than 10 micrograms per deciliter is suggestive of the diagnosis. A multiple low-dose dexamethasone suppression test is sometimes also used, in that urine is collected every 24 hours for 3 days for measurement of cortisol. To do that, 0.5 milligram dexamethasone is given orally every 6 hours, starting at 8 a.m. on day 2 and continue on day 3 for 2 days. In normal subjects, urine-free cortisol is decreased to less than 25 micrograms in 24-hour urine, or less than 50% of its baseline level on day 3. If urine-free cortisol is not decreased compared to the baseline level, then it is suggestive of Cushing syndrome. Another screening test is the measurement of midnight serum cortisol, or salivary cortisol, since cortisol production is normally suppressed at night. In patients with Cushing syndrome, midnight cortisol levels are elevated, so you may see the loss of diurnal variation in cortisol levels, but this is not always the case and are less helpful and usually less recommended. Here are a few useful points. If a single cortisol measurement is to be taken, this should be done at midnight, not the morning one. Some endocrinologists favor salivary cortisol measured at midnight, but this test usually needs to be sent to a reference laboratory and requires high sensitivity assay because salivary cortisol concentration is much lower than serum cortisol concentration. The diagnosis of Cushing syndrome. When the findings of the above discussed screening tests are abnormal, more definitive testing should then be performed to determine the source of the overproduction of cortisol. Plasma ACTH can be measured and is usually low in patients with adrenal tumor. Plasma ACTH concentrations are normal or moderately elevated in patients with Cushing disease. Plasma ACTH concentrations are often markedly elevated in patients with ectopic Cushing syndrome. High-dose dexamethasone suppression testing can be used to differentiate Cushing syndrome caused by adrenal tumors or non-endocrine ACTH secreting tumors from pituitary Cushing disease. Some patients with Cushing disease may fail to suppress cortisol with low-dose dexamethasone suppression tests or give false negative test results. Such test results can be assessed by giving 8 milligrams of dexamethasone at midnight. Serum is collected at 8 a.m. for the measurement of cortisol. In patients with adrenal tumor, or in most of the patients with non-endocrine ACTH secreting tumors, suppression does not occur after the high-dose 8 milligram dexamethasone administration. More specifically, high-dose dexamethasone can be given in 2 ways: 4 milligrams taken orally at 11 p.m. and midnight, or dexamethasone 2 milligrams orally every 6 hours for 2 days. After that, the next day morning, if serum or urine-free cortisol at 8 a.m. is reduced by more than 50%, then it is Cushing disease or pituitary adenoma. On the other hand, if serum or urine-free cortisol is not reduced by more than 50%, then it suggests adrenal tumor, carcinoma, or ectopic ACTH syndrome. Corticotropin-releasing hormone, or CRH, stimulates the secretion of ACTH and then cortisol. In this CRH stimulation test, synthetic CRH, 1 microgram per kilogram body weight, is given intravenously in bolus form at 9 a.m. or 8 p.m. Serum cortisol and plasma ACTH are measured 15 minutes and immediately before, and 5 minutes, 15 minutes, 30 minutes, 60 minutes, 120 minutes, and 180 minutes after CRH injection. An increase of serum cortisol by equal or greater than 20% or ACTH by equal or greater than 50% above the basal level is seen in patients with Cushing disease. A poor response occur in patients with adrenal tumor and in most patients with non-endocrine ACTH-secreting tumor, and those usually already having elevated baseline cortisol or ACTH concentrations. Sometimes additional examination are needed to determine the cause and locate the disease. In addition to use CT scan and MRI for localization of tumors, selective inferior petrosome sinus sampling for ACTH measurements before and after CRH administration can be helpful. If the ACTH level in the inferior petrosome sinus vein is similar to the peripheral vein, this suggests a non-pituitary source of the ACTH. In Cushing disease, the ACTH level in the inferior petrosome sinus vein is much higher compared to the peripheral vein, usually 2 times higher at least. Here is the laboratory evaluation algorithm with the suspicion of Cushing syndrome. Basically, this diagram covers the screening process and tests we discussed and described earlier. If these tests are abnormal, then move to confirmatory tests. If these tests are normal, then Cushing syndrome is excluded. With positive findings from screening tests, you then move to diagnostic testing with the overnight low-dose dexamethasone suppression test and high-dose dexamethasone suppression test, which were also discussed earlier to determine the suppression of cortisol secretion. If there's a lack of a suppression, then you need CRH stimulation test. An increase of ACTH suggests Cushing disease or ectopic ACTH. And if there's no response of ACTH, then it is adrenal tumors. Thank you for joining me on this Pro of Laboratory Medicine on hypercortisolism.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.